A very good afternoon to one and all. Welcome to the POPMA Study Club regular series. Today's date is 15 July 2025, and from 3 p.m. onwards, uh, we have reached almost the middle of 2025, and we have conducted successfully many study clubs under the umbrella of POPMA. I am Dr. Bhuvan Nagpal, the president of Practicing Oral Pathologists and Microbiologists Association. I welcome everyone to the POPMA Study Club, and today's topic for the lecture is Unravelling the Mystery, a comprehensive exploration of neck swellings. And I would like to introduce our guest speaker, Dr. Shivani Mungala. Dr. Shivani Mungla, madam, she is a passionate and budding oral pathologist, and she is currently serving as assistant professor at SVS Dental College, Telangana. She is also lead oral pathologist at Energy Infotech Solution, Hyderabad, and she is also the youngest executive member of POPMA. So, welcome, Dr. Shivani. And she has taken up such a unique topic which is of very much relevance in the clinical practice as far as my experience of more than a decade is concerned. So, welcome, ma'am. Nidhi, ma'am, are you there? For today's session, our moderator is Dr. Nidhi Jadhav, ma'am. Over to you, ma'am, also for further Q&A section. And one more small announcement I would like to make to all the viewers that POPMA is conducting its first Practicing Oral Pathologist Conference, that is POPCON 2025, which is an initiative by POPMA. And the theme of the conference will be Atmanirbhar Oral Pathologist, making oral pathologists self-sufficient. And that will be conducted online on 4th and 5th of October 2025. So I request everyone to register for the conference and enjoy the knowledge extravaganza during those 2 days, and you will get a plethora of information pertaining to the specialty oral pathology practice. Thank you so much, and over to you, Dr. Shivani. I request everyone to keep their videos on the off mode.
Hello, good afternoon, everybody. It's a privilege. And as a budding oral pathologist, obviously, this is an honor which I have been received to tell about the study club. Yes, as Bhuvan sir said, this is a unique topic. Even I have explored so much as a budding pathologist, and I wanted to share the insights. I'm sharing the screen sharing. Sir, is my screen visible?
Yes, your screen is visible. Just
and I'm audible.
The full, yeah, you can go ahead.
Okay. Yes. Can I start?
Please go ahead.
Yes. So today's interesting topic, that is unveiling this mystery, a comprehensive exploration of the neck swellings. So when I was a PG, my professor Dr. Vijay Kumar has always used to behind my back that you have to see the pathology in the lens of questions. So even today we are unraveling the mystery of neck swellings. So we'll be dealing with the questions, that is what, why, how, and when. So coming to the first question, that what are neck swellings? Any abnormal growth or development from the level of the skull to the base level of the clavicle is defined as neck swelling. And when we want to categorize that neck swellings, it will be coming in developmental defects or hypoplastic reactions. It can be inflammatory disorders and followed by the neoplasms. And this can vary from different size, shape, and from non-threatening to the life-threatening scenarios. So again, under what are neck swellings? They can be further classified as lateral neck swellings, unilateral parotid and submandibular swellings, bilateral parotid and submandibular swellings, midline neck swellings. So when we come to lateral neck swellings, it can be ranging from the branchial cleft cyst, non-specific lymphadenitis, infectious mononucleosis, tubercular lymphadenitis to malignant lymphoma. And when we say unilateral parotid and submandibular swellings, it can, it can range from acute silidinitis, lymphoma, pleomorphic adenoma, oncocytoma, and mucoepidermoid carcinoma, acinic cell carcinoma, etc. And the bilateral parotid and submandibular swellings can have endemic parotiditis, Sjogren's syndrome, tuberculosis, HIV, salivary gland disease, and much more. And midline neck swellings are the basics where the thyroid neoplasms or benign thyroid lesions can be seen in the midline neck swellings. Coming to the American family of physicians, those people have given or the etiology of this neck swellings, and they have divided the category into subacute, acute, subacute, and chronic. And in that categorization also they have given common, uncommon, and rare. So in acute form, we can see the microbial infections, that is cytomegalovirus, Epstein-Barr virus, Staphylococcus virus. All these infections are taking the acute and the most common etiologies for the neck swellings. Apart from the uncommon ones, they are acute silidinitis, hematoma, HIV, virus infection, tuberculosis, etc. And the subacute, that is common, will be the squamous cell carcinoma, and subacute, uncommon, will be amyloidosis, lymphoma, metastatic cancers, parotid tumors, etc. And in this, rare lesions can also be seen, but these rare lesions are, like zero to null in the Indian, demography. And when you come to chronic lesions, we have thyroid pathology, which is very, very common. And then apart from the uncommon one, we can see lipoma, thyrobrosil cyst, Sjogren's syndrome, and branchial cleft cyst. So the next question would be why we need to know more about this neck swellings. So as a dentist, focusing just on the teeth is not our aspect. The surrounding structures is equally important as the teeth. Now, assessment of the neck is important because it contains regional lymph nodes, major salivary glands, hyoid bone, larynx, trachea, thyroid, and parathyroid gland. And as an oral pathologist, we need to know more about neck swellings because the neck swellings are coming to the ENT clinics and hospitals, and they are not coming to the oral pathologist. So this is the background which we need to work on. And when we say neoplasms of the neck swellings, we can see that India has a concerning amount, that is 23% of the males were having the neck swellings as the cancer, as a carcinoma, and the females were 6% of the females were affected with the neck cancers. And the studies also reveal that. So let us dive deep in. That is, in 2013, 106 patients were evaluated in the ENT department for 1 year, and the outpatient and inpatient flow was seen. And the age group were distributed from 0 to less than 40. And the distribution of the neck masses were seen as thyroid, which was 42%, and then followed by the lymphadenopathy, that is 29%, salivary glands, parapharyngeal neck masses, and cystic swellings, that is 9%. In 2021, the similar 100 patients, which were outpatient and inpatient, were seen in the ENT department, and that was studied for 2 years, where FNAC and biopsy were also performed for the neck swellings. And the age range here is also from 18 years to less than 71 years. And the next neck distribution masses were from 43% of the thyroid lesions were seen. Apart from that, lymphadenopathy was 23%, salivary glands 18%, congenital masses 8%, and miscellaneous masses was 7%. Similarly, some other study in 2022, 50 patients which were walking into the ENT department as well as in the pathology department were seen for 1 year, where cytology, radiology, histopathological tests were also performed. And the age range was 5 years to 75 years. And the distribution of the neck masses were divided into benign cases, that is 81%, malignant cases was 18.1%, followed by the thyroid lesions, that is 70.2%, along with lymphadenopathy and salivary gland neoplasms. The one more interesting study, which was done in 2017, where 150 patients from the pathology department were studied and where FNAC was performed. And the age range was quite interesting, that is age 1 year to the 80 years. And the distribution of the neck masses were inflammatory swellings, which was accounting 48.67%, benign cases 36%, malignant cases 13.3%, and non-inclusive cases, that is 2%. Followed by lymph node, which were which were affected, that is 45%, thyroid masses with 24.67, followed by the salivary gland. One more similar study were performed in 2019, where 160 patients were evaluated for 4 years, where clinico-pathological and radiographic tests were performed. And the age distribution here was also 5 years to 75 years. And the benign cases, which we can see, that is 86.9% of the cases, malignant was 13.1. Again, the masses were categorized into thyroid masses, that is 73.2, lymphadenopathy with 6.9, and salivary gland by 3.1. So by seeing all these 5 articles, what interesting fact we could know? That was females were most commonly affected than males. There is a wide range of age distribution of the neck masses. Clinico-radiological, clinico-pathological, and radiological approaches will give you the effective way of diagnosis this neck masses. And the most prevalent cases were of benign, inflammatory, followed by the neoplasm. And when you see in the category wise, the thyroid masses were frequently seen, followed by the lymphadenopathies and the malignancies. So you got to know why we need to study. The next question is how to identify the neck swellings. So the important point here, one has to understand that odontogenic source, that is dental caries or the infection space infection, any infection or any source of the infection from the odontogenic source can cause this neck swellings. And there is a multiple structure in the neck. As we told, there is hyoid bone, there is salivary glands, there is larynx, pharynx, everything. So there's a difference in origin, difference in their features, difference in their pathology, and different in their prognosis factor. So that's why that is how you need to identify the lesions separately. Again, how we used to identify the lymph nodes, the same thing, visual inspection, palpation. And how do you do that? We have to slightly incline the position of the patient, and the clinician has to stand behind the patient for the inspection and palpation. The important parameters to identify the neck swellings are anatomic site, enlargement of the site, size, consistency, pain or discomfort, mobility of the neck, and difficulty in swallowing are some important parameters as a clinician we're supposed to know. And when we know and when we check for such things, the diagnosis or to identification of the neck swellings become easy. Apart from that, there are few more points as a clinician we need to know, that is duration. If the duration of the swellings is less than 3 weeks and the size is less or equal to 1.5 centimeter, it is usually of inflammatory in origin. Now, suspicious lesions, they show more, the size of the lesion of the neck mass will be more than 1.5 centimeters. The duration will be more than 3 weeks, along with the combining features. And those combining features are progressive enlargement of the mass, non-tender on palpation, firm or hard in consistency, firm rubbery mass, immobile fixed nodes, mated lymph nodes, and attached or underlying skin, ulceration of the skin surface. Apart from this, there are some more features will give you the idea, that is only neck mass. Neck mass when it is associated with fever. Neck masses where they along with change in voice, difficulty in swallowing, neck masses with weight loss and loss of appetite. So all these things we have to additionally add during our inspection and palpation sector when we see a neck mass. So apart from that, we'll see how how a neck mass is there, how does it appear, and how do you understand where to categorize each of the neck masses. So coming to the first one, that is thyroglossal cyst. So how do you understand it's a thyroglossal cyst? It is always localized. The swelling is there in the midline, and when you palpate or inspect, it's a soft or firm in consistency and compressible neck swelling, and it appears something like this. Coming to the goiter, which is very frequently seen in Indian population. So below the thyroid cartilage in the midline, firm compressible, movable, and multinodular will be its appearance. Something like this. Coming to the dermoid cysts, they arise from the mylohyoid muscle and they cause double chin appearance. So when you ask the patient to tilt their head down, you can see there's a formation of a double chin appearance. Movable Davine consistency. So something like this. So you can see there is exactly the swelling is below the chin. Apart from that, sebaceous cyst, which is not so common, but we need to know about them. Compressible and doughy consistency, pleomorphic adenoma, soft, firm, movable, and yes, we all know it's a painless swelling. Ethnic cell carcinoma and mucoepidermoid carcinoma will show you fixed to skin type of mass, ulcerated, and erythematous, neck masses. Coming to the thyroid, which is again very most common as we have seen previously. So the solitary node or solitary mass, there is a high risk of them for transforming, so for the malignant transformation. Usually thyroid masses will not show you visible signs, but what are you going to check for? That is, if it's a female patient, history of hypo and hyperparathyroidism. Elderly patient with iron deficiency will be your clue point, and the past history of radiation will give you a clear sign that it's a thyroid nodule, a thyroid mass. In the thyroid masses, usually benign and malignant are equal. And when you see parotid gland associated neck swellings, they are benign. Most of them are benign. Coming to the malignancy, they are indurated nodes, fixed and enlarged, and history of a progressive enlargement will give you idea that it can be a malignant in nature. Infectious mononucleosis, it can occur in different lymph nodes, that is submandibular, cervical, optical lymph nodes. And enlargement, painful, soft and rubbery in consistency like this, and bilateral in nature, can give you an idea that it is an infectious mononucleosis. And the most common one, that is tuberculosis, submandibular, cervical lymph nodes. Initially, they will be painless, firm, movable. And when the studies were seen that 35% of the tubercular cases which were extrapulmonary, where the cervical nodes were positive. So even in the extrapulmonary cases of tuberculosis, the patient will, patient suffering from cervical lymphadenopathy or the tuberculosis in the tubercular lymphadenitis, the cases can be 35%. So we have to be well aware of such conditions. So how are you going to identify? Like this, the underlying skin will show you the erythematous changes. So thorough clinical examination, appropriate radiological investigation, followed by the cytological evaluation will give you a perfect diagnosis for the neck masses. So clinical evaluation we have already seen. Coming to the radiographic evaluation, the initial diagnostic test or the choice, that is contrast enhanced computed tomography, that is CT, which will provide us a valuable information regarding the size, extent, location, content, and consistency of the masses. So there is I have read so many articles, and it were like first the textbooks and articles said ultrasound. Later it went to the CT. So we can go either hand in hand, CT with ultrasound followed by the MRI, or CT first, later ultrasound. We can choose according to the need of the patient. So this is how a neck swelling can be seen in the computed tomography. This is again a thyroglossal cyst which can be seen here. So again, the American Family Physician Journal has given us a preferable imaging modalities for the neck masses. So that is, if there is a non-pulsating solitary mass or multiple neck masses, we can go for contrast enhanced CT. If there is a pulsating neck mass, then CT along with the CT angiogram will be helpful. And the patient with the neck masses and the history of the cancer. So we will do the CT as well as the PET scan. So this is positron emission tomography, stands for PET scan. So we can do either both, or first PET scan, later CT scan. According to the need of an hour, we have to take a quite amount of decision. Coming to the cytological evaluation. So cytological evaluation, the most preferable diagnostic, criteria, or diagnostic first line of diagnosis will be FNAC. So fine needle aspiration cytology, we say, that is the procedure by where the small amount of the tissue or a cell is aspirated from the pathological lesion. And it is by 21 or 22, somewhere it is written 25 gauge of needle attached with the 10 ml of disposable syringe. So we'll learn how this FNAC procedure can be taken. So first you can see there is a well-defined mass, you can see, and there is a needle which has inserted in the mass. So this is needle positioned within the targeted tissue. So here there is this plunger, and this plunger is at the rest position. So what are we doing? We are pulling the plunger to get a negative pressure. And as we get some negative pressure, we are going to do make a back and forth movement, so that whatever the aspiration is there, it has to be taken with the syringe, within the syringe. So back and forth movement has to be done. After that, we can see, negative pressure is releasing, and releasing while the needle remains in the targeted tissue. So the plunger is removed entirely. After that, we are going to remove the needle, and later on we are going to remove the needle also, and the air has to be drawn into the syringe. After that, we are going to make a smear out of this. So when you do this FNAC procedure, why are we performing? Because directly biopsy is not a great, because aesthetic problems, and when you say suddenly we are going to perform a biopsy, the patient become apprehensive. So first we need to know the nature of the neck mass. For that, FNAC is good enough to tell us the nature of the neck mass. Again, after knowing the nature, we can go for the biopsy treatment. Obviously, that is mandatory. So biopsy procedure is later when you know which category it belongs to. Either it's inflammatory or it is neoplastic in nature, and the FNAC will provide you the answer for what is your further step, that is either biopsy or some inflammatory condition or infectious condition. So are we going to treat with the antibiotics, and it is going to subside or not. So coming to the smears, as we told, so now the aspiration has taken. So when the smear, the appearance of smears, if the smear is thick, shiny, and when when you make a smear, after that it dries up as a gray thing, then there is a high cellular content in your aspiration. The lymphoid infiltration can be seen in non-neoplastic as well as neoplastic lesions. So we have to, in neoplastic lesion, apart from lymphoid infiltration, check for the epithelial cells, so that we can correlate the diagnosis. Reactive pattern in a slide, it depends upon degree, number and size of the germinal centers which are affected and which are aspirated. Apart from the routine HNE, pap smear, Giemsa stain, Zeal-Nielsen stain, Gram staining, all these are different kind of stains which we can use to identify the lesions. So coming to some few lesions where I've kept it simple, and I could find how much I could find. I have just attempted in this PPT. First is follicular neoplasms, because as we saw that thyroid, thyroid lesions were more, had more prevalence. So I wanted to keep the thyroid lesion first. So coming to follicular neoplasms. So here you can see these are these are the cells, and this epithelial cells, they are equal in size, and they are forming a small microfollicular manner that will give you an idea that it's a follicular neoplasm of the thyroid. And how do you identify such smear, or how do you identify such lesion? That is, it will be highly cellular, often blood smear, equal size of the epithelial cells, and they will form a cluster throughout the smear. So that is your identification point. Coming to the cystic nodule of the thyroid. So brown color fluid of colloid and altered blood cells, many foamy cells which will be seen, and those foamy cells will be indigested by the indigested cells, and hemosiderin pigments will be seen. Sparse amount of epithelial cells, they will be showing a degenerative changes. So here also you can see that there are some epithelial cells around with blood, that is RBC cells around the smear. Next is branchial cyst. So brachial cyst cytological smear, they contain dyskeratotic, atypical looking squamous cells, which we can see here clearly. Pycnotic nucleus can be seen, which is also seen in this smear. How to criteria of diagnosis? So when you aspirate, thick yellow pus-like fluid will be coming. Keratinized cells, squamous epithelial cells with variable maturity will be seen on the slide. So that will give you an idea. It is a brachial cyst. Coming to the metastatic squamous cell carcinoma. So obviously when we say carcinoma, we know that dysplastic features will be seen more. But apart from that dysplastic, the aspirate cannot might have the entire epithelial cells, but whatever epithelial cells which have reflected in the slide will show you pleomorphism. That is how which we can see here also. The cellular pleomorphism can be seen. Nuclear hypochromatism can be seen. Lot of amount of inflammatory cells also will be seen in the metastatic squamous cell carcinoma. Coming to the Hodgkin's lymphoma, when we say Hodgkin's lymphoma, we have that Reed-Steinberg cells, so that mono to binucleated cells will be seen in your smear. Apart from that, inflammatory cells will be seen, and also here the vacuolated cytoplasm, vascular nuclei can be seen, well demarcated, and demarcated prominent nucleoli can be seen in the Hodgkin's lymphoma. Coming to the tuberculosis, so we can see whatever we can see in H&E section is similar thing what we can see in the cytology smear also. But apart from that, the blood also comes in the aspiration. So epithelial histiocytes, they are often seen in the clusters. What we can see here, the Langhans cells. Sometimes if they are aspirated, we can see the Langhans cells. In this image, there is no Langhans cells. The diagnostic criteria will be cheesy material is coming out as an aspiration. So you can understand it's a caseous necrosis that is happening inside. Pus or yellow fluid can give you an idea that there is a secondary infection which is going on in this tubercular lymphadenitis. So what are we supposed to do when we encounter such cases? So when we encounter such cases, first is history. We'll take the past medical history because that will provide us with the information like the patient is having thyroid or not, hyperthyroidism, hypothyroidism, all that thing. Dental history. Sometimes the clinician is failing to identify the neck masses. Example, the previous clinician has forgotten and he has not seen or he has not inspected neck swelling. The patient is again coming to us. Okay, so that dental history is important. Habit history, drug history is important. Why habit and drug again? Some are associated like oncocytoma, ethnic cell carcinoma, Warthin's tumor. All this are also habit associated. Somewhere I've read in articles that the smoking, apart from the smoking, is also causing in Warthin's tumor. They are also causing hypersensitivity reactions and causing the swelling. So the Warthin's tumor can also happen in neck, and for that also habit history is important. Drug history, that will give you a radiation history if the patient has undergone some neoplastic changes previously or he has been treated for cancer previously. So after that, teeth evaluation. So we have also seen in the previous slide that odontogenic source can also cause the neck swellings. So we will check for abscess, apical periodontitis, space infection. We'll take a radiograph of the jaws. We'll also evaluate the sinuses to eliminate if the tooth is the cause of neck swellings or not. After that, we'll do a physical examination of masses. Already we saw location, size, duration, consistency, temperature, everything we're going to check. Later, soft tissue examination. So we are going to check inside. We are going to check inside larynx, pharynx, nasopharynx, nasal cavity should be inspected very well. So in this inspection, we will get to know that any erythematous changes, proliferative changes, any slug on the area. All this can be all this can help us in diagnosing the neck swellings. Apart from that, radiographic examination like CT, ultrasound, PET, MRI, accordingly or according to the patient, you will decide and do. One more better, the thing is, if the mass has failed to resolve within the 2 weeks, then FNSC and biopsy should be advised for the patient. If you know, say example, infectious mononucleosis and the Epstein-Barr virus associated infections, so those will also show some amount of changes in the larynx, or in the in the nasal cavity or nasopharyngeal areas, that will give, and the patient will tell you there is some harshness of the voice, difficulty in swallowing. So all this, you are supposed to join the dots and then later come to the final diagnosis of the neck swellings. So I have kept the presentation as small as possible. So my take home message will be expand your horizon, because sometimes not only the teeth which we are concerned about, it's the surrounding tissue. Also, knowledge is the key. So this topic was also very new for me, and I had to go through many articles and textbook to get into, to get and collectively get an information of 18 pages. So knowledge is important, keen and alertness. And because not every case is a straightforward case, sometimes it will just trick you. So it is our responsibility as a dentist to check every aspect, along with the teeth. Every surrounding tissue should be checked. Active discussion. If you have encountered any of such patients in your practice, so please come up, have an active discussion with your seniors, with your colleagues, with your teachers, anybody possible. And the last word I would tell you, that oral pathology is a world of hidden and unanswered question. The perfect for those who is driven by curiosity and passion to explore the unknown. So I would like you to explore the possibilities, and I hope that I have solved some mystery of this neck swellings. Thank you.
Yes. Uh, Over to you, Nidhi ma'am. I think you should.
Vani, it was a very nice presentation on neck swellings, no doubt. It was a very good presentation. Do we have any questions from the audience? I don't think there are any questions in the chat box.
Yeah,
Anybody wants to ask any questions directly to Dr. Shivani?
Dr. Shivani, it was wonderful, brilliant presentation. And if you allow, can I add some of the things and
Please,
can I show my
please.
cases,
Yes.
the
I would
real
like.
life cases?
Yes,
With
sir.
your
Please.
permission, Nidhi ma'am,
Yeah,
I'll
sure,
just
sir.
share.
Why not? Definitely,
Yeah, yeah,
sir.
Sir, am I supposed to stop the presentation?
yeah.
Stop the
Please.
screen sharing? Yes.
You're able to see my presentation.
Yes, sir.
My
Yes, sir. Yes, sir. Yes, sir.
Yes.
But, sir, can you
it's
please
not.
keep the.
Yeah. I think now it is full screen. No.
Yes, sir. Yes.
So I'll just share. This is my 10 years of experience and data, because I do lot of FNACs, and I must tell you that now approximately 10,000 FNACs I have done in my career. So I'll just share this study which I have done from my archival records, that 65% of head and neck pathologies, they constitute that whatever the pathologies which are coming to a diagnostic center, 65% is from head and neck region. So now in that 65, if you see head, 20% are from that region: preauricular, infraauricular, submandibular, submental, scalp, temporal, infratemporal. Parotid only constitutes 3%. Neck, which can be epidermal inclusion cyst or it can be lymphadenopathies, 29%. And thyroid is 13%. The rest 27% is breast. That's why we have majorly more malignancies for breast. Now, this is the spectrum of lesions which you get. One is the non-specific lymphadenitis. Tuberculosis again is very common. Organizing abscess. The major reason sometimes is the teeth. Like you get any periapical lesion is there, and because of that, which is not healing. Then metastatic squamous cell carcinomas. Majorly, the patient presents when it has reached beyond the oral cavity. Then goiter, colloid goiter or nodular goiter, they are very common. Pleomorphic adenomas. And yes, you are absolutely right that females are most affected ones. And I have seen mucoepidermoid carcinoma diagnosed on FNACs, adenoid cystic carcinoma, lymphomas, both Hodgkin's and non-Hodgkin's. Thyroid malignancies are difficult to diagnose. They have their own gray area because FNAC, you need a radiological part to be involved with. I'll just share some of my 5, 6 cases, not more than that, because we have time with us, and then whatever the inputs I can give, because it's a study club. It's like we all are here to share our thoughts and discuss. So now you see a 17-year-old female. She had, you can see the major aphthous ulcer above the it is near the labial mucosa of upper lip, and she had lymphadenopathy. The major thing which you have also highlighted, Dr. Shivani, that we sometimes miss the extraoral findings, and which are very important. So you can see this was the done, FNAC was done, and we get pleomorphic, uh, polymorphic kind of lymphoid tissue. So it is towards reactive lymphadenitis. 52-year-old male patient. He is a chronic smoker from past 30 years. And when it was done, so
But যখন patient ও miss
Dr. Abhishek, are you saying something?
nothing.
So this patient, when I did the FNAC, it was full of a yellow colored fluid, and you can see that lot of dysplastic squamous cells. So it was metastatic squamous cell carcinoma. 31-year-old female patient with the parotid swelling, and you can see the how it is highly cellular and lot of chondroid material and cellular type of, the cellularity is quite high, and you can see different polymorphic cells, and these are myoepithelial cells, and lot of chondroid myxoid type of material is you can observe, and so it is pleomorphic adenoma. This was a lady which has lot of extraoral swellings over the neck and lot of sinuses and unhealed kind of lesions. So when we did the FNAC, and lot of necrotic material came with white cheesy material was there, and we can see that it was some areas granulomas were present, but in this picture I cannot show you a typical granuloma, but the majorly it is of the necrosis, caseous necrosis is there with lymphoid thing, and you have to always correlate clinically and radiologically, because the sensitivity for FNAC technique is just 60 to 80%. Another 64-year-old male patient, chronic smoker from past 40 years. You can see the syringe is full filled with yellow colored thin material, which is particulate in matter. And yes, you can observe a lot of dysplastic cells. The squamous cells are dysplastic and metastatic squamous cell carcinoma. It's a lady, she was also a smoker, and she had pharyngeal swelling. So, see, lot of squamous cell carcinomas are coming. Again, neck swelling, but that is post-auricular. And when I aspirated, it came as a very dirty, cheesy, grayish white kind of material, which was full of polymorphs. Neutrophils are there, but along with that, you can observe that these squames are there. These squames. So it is infected epidermal inclusion cyst. A swelling, the thyroid swelling, the main thing when you observe, you have to ask the patient to deglutate. So when the swelling moves and you observe it, and then you do some, in cases of colloid goiter, you will get either a straw colored fluid or a brown to black color fluid, and sometimes cellularity is also there. So it is a nodular goiter. You can see that the follicular cells are there, and there is no atypia, nothing, and behind a background of thin colloid is there. Again, from a dental abscess and extraorally it is presenting, and 27-year-old male patient, and when it was aspirated full, the syringe was completely filled with the pus, and when slide was maced, all necrotic material with acute inflammatory cells, the polymorphs are there. So it's organizing abscess. Thank you so much, Dr. Shivani. I took time from your presentation to share some of my cases. I hope everybody.
That was needed. That was needed, sir. That was needed.
I think questions
Actually, that
we
has
can.
added to the knowledge on this topic. Dr.
No, I was
Shivani
not
covered
prepared,
about
but
the
I thought I should share some of the things. I have uh, almost more than 200 cases which I have documented, the exceptional cases with profuse swellings and all those things. And the crux of the story is that we are the people who see lot of head and neck related and oral related cases, and we should master those things. It is
Exactly, sir.
perfectly within our scope. So many
Yes.
people have
That
left.
is why I also highlighted that the cases are going to ENT and general hospitals. So when we are, listen, if the seniors, obviously you guys are already doing so much. So if somebody is like me who's budding and the juniors, I will ask you guys that please make a brochure. In that brochure, add neck swellings also, so that वो cases हमारे पास आ जाए. It should not go to the ENTs and all. And if somebody is going somewhere and they have to go to labs at least to see how they are processed or how the aspiration is coming, what is there in the sites, and if somebody is interested, they can go to the diagnostic centers to learn about the neck swellings also.
Along with oral pathologists, we should always meet up the ENT people also, because lot of cases like they also take lot of oral biopsies from tongue or from cheek.
So regarding the cases, they were definitely diagnosed later also with a biopsy, or all on FNAC only, the ones that you have shown?
Yeah, some were diagnosed after biopsy, like pleomorphic adenoma and even the epidermal inclusion cyst. But abscess and all, it was not done. The major issue comes with the thyroid part, ma'am. Because what happens, thyroid is a very vascular organ. First, you have to be very sure. You have to counsel the patient, because just seeing the needle only, the patient gets so much apprehensive. You just see that how when we take out the scalpel, so how much that apprehension will be. So thyroid neoplasms they are very difficult to diagnose on
Just
FNACs. You need a very expert hand in that. So the common benign ones are easy, but otherwise for papillary CA of thyroid or follicular, even I need
But
second
at least we are
opinions.
able to know the category. The category part, at least we are
Yes,
able to.
that Bethesda categorization is there. So, anyways, this is what we can have learned over a period of time. Yeah, and there's so many things. It gives a clue, and in that change sometimes happens. And for breast also, though it is not in our domain, but again it's a ductal structure. So lot of infiltrating ductal carcinomas are there in India. Every third, fourth case which comes for breast FNAC, they have that malignancy, and in in that tissue, it is very there are many chances to miss that. So it's always advised a biopsy. I'm always the pro advocate for histopathology, that biopsy should be done. But the problem is uh, still in India that compliance is you have to
Difficult.
counsel the patient a lot for that thing.
Dr. Shivani, there was some term used in infectious mononucleosis. You used optical lymph nodes. Can you highlight on that if possible? Optical lymph nodes.
1 second, ma'am. I just have to see the PPT. Ma'am, in infectious mononuclear optical lymph nodes, ma'am.
I'm
Yes.
hearing it for the first time. I thought I'll just ask you.
Yes, ma'am. It's optical lymph nodes is I think I don't know, but I think it's around the eye where if there's any prominency, if they might see. So that is what I feel, because that is what I have seen it from the article, which was specified as optical lymph nodes.
No problem. We'll also check in the literature.
Yes.
I've heard it for the first time, so thought I'll ask you.
Yeah. Even I have also heard for the first time.
That was in the article, ma'am.
No, we'll find out. No problem.
Yes, ma'am.
So I think anybody would like to add something to the case. We have 10 more minutes and then we can wrap up. Any more questions or any inputs? Dr. Banerjee, you want to add something? If you are there.
I think he has left, sir.
Yeah.
Sir is there.
He's there?
Yes, sir. Yes, ma'am. He is there.
I think then if no questions and lot of good comments for you, Dr. Shivani, champion Shivani, very informative session, very beautiful presentation, crisp and to the point. A lot
Thank
of
you,
good
sir.
comments
Thank you.
from a lot of people. So then I think we have our next study club on 26th of July. That is the management of systemic emergencies, so medical emergencies. So that can happen anywhere, either in a dental clinic or even oral pathology clinic. So that will be there. And before that, on 19th, there is a hackathon in collaboration with Tumor and POPMA. So I request everyone to please put on their camera so that we can have a group photograph. Before that, ma'am, please give a token of appreciation to Dr. Shivani.
Thank you, Dr. Shivani, for such nice presentation.
I am supposed to be thankful because I have got this opportunity, and I will be grateful for POPMA, first of all, the association where we all stand. And because of the series, many of us are getting an opportunity, a platform where we can speak. We have so much inside us, but we do not usually get a platform where we can express ourselves. So I would actually be grateful for POPMA. Next is Dr. Bhuvan sir, to come up with such an idea where all of us are equal and all of us have a stage, a platform where we can share our ideas and presentations. I would be grateful for you. Thank you.
And always an opportunity to learn also.
Yes, ma'am.
If we
Yes.
attend these sessions, they are really worth it.
Yes.
At least we everybody interacts in some or the other way. Suppose now it was not at all prepared. When she was finishing, I thought that she will finish in 40 minutes. So if possible, I'll also share some of my cases. Otherwise, even I don't get a chance to share all those.
But it was an add-on, sir. It was a good add-on, but.
So it was not planned, but anyways, it was on spot. And I request everyone to please put on their cameras. We all can have a group photograph.
So you want me to click?
No, I'll click and yeah, I'll just. One more. Thank you so much. And those who want to see the content of the study club, it's already there on POPMA channel, which has all the different series of the lectures since 2024. And I have already shared the link in the chat box for the conference registration, as well as those who are interested to be a part of POPMA. Thank you so much, and till then, stay tuned. We will be back and uh, with another POPMA study club multidisciplinary series. Thank you so much. Thank you so much,
Thank
Dr.
you, sir.
Shivani.
Thank you, ma'am.
Much
Thank
all
you,
the
Dr.
participants.
Thank you, sir.
Okay.